Friday, Baylor College of Medicine and friends of Baylor. Well, my sister's been after me. She said, when are we going to have a Q&A? She had a lot of questions from a lot of her friends, and I've completely neglected her for like several months now. So a lot of the questions are on COVID, but a lot of the questions are not COVID related. So let's just see. Let's see what the questions are. I feel like the old Johnny Carson show. I have the answer. No. Anyway, how bad is a repeat of COVID? People are worried when they've had a repeat case. Is that really bad for you? It's not unusual. Most of the time, people get a shorter version of the disease because they're partially immune. And it looks like, there's some data emerging that partial immunity is good, so it'll be a milder case. That's not necessarily true of people who are immunocompromised or elderly. And so, you prefer not to get a second case, but if you've been vaccinated or had a previous infection, you're gonna probably handle it better because you're also partially immune. Do repeat infections increase chances of long COVID? Okay, that's a complicated question. There's a paper in Nature Medicine last November that looked at the number of veterans who had multiple COVID infections, and they showed that they were more likely to have lung and heart disease and neurologic diseases if they had serious infection. But it was mostly in the older group of veterans. And so there's too little data right now to know for sure. One thing that's interesting is there was a recent paper that showed over the last year or so the incidence of long COVID is declining, probably as a function of two things. One is that people have either been infected or vaccinated, and secondly, that the current strains or variants of the virus are probably less virulent. But the best way to reduce your chances of long COVID is to get vaccinated. Keep up with your vaccinations, and there's plenty of data to show that vaccinations reduce the incidence of long COVID even if you're infected. So again, the answer almost always is vaccination if you can possibly get it. Okay, when will this year's COVID vaccine be available? Pfizer, Moderna, and Novavax are all producing vaccines that the CDC says will be available in late September, early October. And one person asked, what variant will this year's COVID vaccine target? It's going to be the XBB 1.5 variant. We've talked a lot about that in the last couple of weeks. This is not the dominant variant right now. The dominant variant is EG5, which is the fastest growing variant. And it is a branch from XBB. It branches off from XBB, but it's pretty closely related. The concern, of course, as we talked about, was BA 2.86. We're all following that to see whether or not that becomes dominant. The reason that's a concern is it's quite different from the XBB strain, and so it's we don't know. We think the vaccination will be effective, but probably less effective against 2.86 than all the variants that are around now. This is a good question I didn't know the answer to. Does it matter in which arm you get your vaccination? Well, it turns out there was a study in Lancet that showed you actually get a better immune response if you get vaccinated the second time in the same arm that you got the first one. So, yeah, they looked at a bunch of patients between March and September of 2021 and looked at killer T-cell generation based on vaccination, and the ones that got it in the same arm had a greater response. Interesting. There's not enough real data to show it. I'd say get it in the arm you want. There was not the same kind of response in the same arm to the spike protein, like a big antibody surge to the spike protein. It was just a natural killer cell. So I don't know. I personally just get it in whatever arm you want. Here's a lot of interest in leprosy. So somebody asked, what's going on in Florida? I have no idea what's going on besides a hurricane. But is the increase in Florida that I mentioned a month ago or so related to the infected armadillos? So that's a good question. I spent a lot of time trying to figure this one out. So armadillos do carry the bacteria that causes Hansen's disease, which is leprosy in humans. And in the past, the armadillo population was really confined to just a few states, mostly Texas and Louisiana. But in the most recent past, it's expanding. It's as global warming happens, they're moving all over the place, and they are pretty prevalent now in Florida. And if you look at the cases of leprosy, they really were declining from the 80s through the 2000s. Most of the cases before that were due to travelers who contracted leprosy abroad and came back home. But over the last 20, 30 years, the cases initially declined, but from 2000 they're beginning to go up again, and there's been 159 cases reported in 2020. So that's a large number. And we're not 100% sure where they're coming from, but this little guy is suspected. This is a female armadillo, and this is the 9-banded armadillo. Why do they call it 9-banded? It has 9 bands on its side. And you can see that this is the current range, includes Florida, Louisiana, Texas, even Arkansas, but it is expanding its range as global warming happens. And so it is pretty clear that in this particular armadillo, you can find the exact same strain of Mycobacterium leprae as happens in humans. And there was a recent, sort of analysis of the armadillo population, and it supports that truly is a zoonotic and anthropogenic reservoir for this particular Mycobacterium. The trouble is that when you actually look at the cases, doing a real stringent analysis of who's gotten it, not everybody's had exposure to leprosy, to armadillos. Not everybody's been exposed to traveling. So there is some concern that it's just becoming endemic, and the way it's transmitted from human to human is through respiratory droplets. So there's a sense that probably some of that is human transmission, some may be spillover from armadillos. So if you find an armadillo, don't do mouth-to-mouth resuscitation in case it's lying on the road. So I had mentioned a couple of months ago about Candida auris, and somebody asked, what's going on with that? What are the symptoms? Are there cases in Texas? So Candida auris is actually, it's a yeast, which is a microscopic fungus that exists as a single cell that can bud. So it's a type of fungus, but it's a single cell fungus. And it buds, and that's how they reproduce. And they can cause really severe infectious diseases and even death in hospitalized patients and nursing home patients. And most people who contract this disease, actually 1 in 3 patients who contract it will pass away from it. So it's often in blood infections, wound infections, and so this has been a big concern because for one thing, this particular yeast is very resistant to the treatments that are currently available. So the things that we do for other species of Candida, like alba, this one it seems to be resistant, and it was just discovered in 2009, but it is already spreading pretty significantly. And if you look just at the cases that have been reported, 2013 to 16, 19, and 2021, and then most recently, there are 300 cases in New York and 160 cases in Texas. So there is a concern about that. There's a lot of work on trying to develop some antimicrobials for that. So I mentioned this last week, but also, again, people are very interested in when should I receive a flu shot. So I mentioned last week that all the vaccines are quadrivalent. They'll have 2 varieties of A and influenza B. The current guidelines are very standard. Everybody 6 months of age or older. Adults over the age of 65 should be getting the high-dose vaccine, which contains 4 times the antigen of the standard vaccine. As I mentioned, live attenuated nasal spray will be available, flu mist as a quadrivalent for ages 2 through 49. The best time to receive it is really October. If you think about when last year's peak flu season was, it was sort of late December. So 6 weeks after you get vaccinated is when you have your peak antibody response. So, mid-October, would put you perfectly protected. We haven't seen a big uptick in flu yet, and so, we'll see. It's too early in August and early September to get vaccinated, although a lot of people do, just to get it over with. But the people who should is if you're in the 3rd trimester of pregnancy and you want to protect your kid, and also children who require 2 doses and know that they'll have a second dose. It's probably a good idea to get the first dose now. We're going to hopefully get a chance to talk with our specialists in flu, who are who are actually running the vaccine treatment unit. Dr. Piedra, if we're lucky, we'll get a chance to interview him. I'm looking forward to that, hopefully next week. We'll see if he's available. This is a really good question. Do egg allergies prevent you from receiving flu vaccines? So, most of the time in the past when you get your flu vaccine, you have to sign off, I don't have an egg allergy, because a lot of the antibodies are raised with an egg-based development. But this year, the CDC is saying it doesn't make any difference. There's no need, there's no real problem with vaccination, even if people have egg allergies. So in the past, it's been a big issue, but I'm not sure why it's not anymore, but they're saying it shouldn't really make a difference. Talk with your healthcare provider. You can always get a cell-based one. There's different production ways to make the vaccine. But anyway, it's pretty interesting. So some people just ask, how does the flu season look? It's an interesting flu season. Just to remind you, the flu virus is determined by mostly by the two major proteins on the cell surface, the hemagglutinin and the neuraminidase. They stick out here, and you can see and bind to the receptors. There's also a matrix protein that's important, and they're divided into influenza A, or the nomenclature is one of the H's and one of the N's. So they're defined that way, and then influenza B is defined as either the Yamagata strain, where it was isolated, or Victoria, where it was isolated. Influenza C is not a real big pathogen in humans. And if you look at what has been, this is last year in December, the main strains were H3N2 and H1N1. You can see there's not a lot of flu now. This is an expansion of what's here. What is circulating is H1N1 and Victoria. Interestingly, Yamagata is not circulating, but it is in the vaccine. The CDC just published what is going to be used in the vaccine. It's going to be H1N1, H3N2 for influenza A, and it's going to be the Victoria and the Phuket strain from Thailand in the Yamagata lineage. The cell-based ones are pretty much similar for those people who aren't going to be taking egg-based ones. Anyway, it's interesting. It's going to be quite prevalent. Now, if you have any other questions, we got a lot on this week. But if you have other questions you're really interested, it doesn't have to be on coronavirus, just be sure to email me at president@bcm.edu, and I'll answer either personally or I will include an upcoming video. So feel free to write whatever's on your mind. I can't take care of all of your personal problems, but I'll do the best I can. Anyway, have a great weekend, and I can't wait to see you next week.
Newman. You had to beat Seinfeld. You're going to make 181, aren't you? I can feel it. And you will take over the lead at that time. I hope you're proud. I hope you're proud, Paul.